So from that energetic beginning, we're starting to look into this bright future of healthcare. And to join us in this last panel for this year's Congress, I'd like to invite now our other three panellists up, Daniel, Erasmus, Dr. Muna Tahlak, and Niall Dickson. So for those of you who've been here while our panellists settle, you know the drill now. This is how we do it. We get our panellists, in this case we're going to have three very quick presentations just to sort of take us more into this bright future of healthcare. Then we have a chance to unpack that a little bit, pull on some threads with the panel, and then if we have time we'll throw to some questions. If not, you'll get that chance to have that conversation at the Aussie Sundowner, which I hope you'll join us with. So without further ado, can I please ask Daniel to kick us off?
Thank you very much, Ursula. You know, it's interesting to think what drives us to be what we are and to do what we do. What drove you to be in the industry that you're in and be in this room today? A large driver of my own life has been fear. Fear of becoming less of who I am as I grow up. Fear of not being the father that my kids knew when I'm older, and fear of not being the husband that my wife married. And the reason for this fear was having witnessed firsthand what severe depression does to you. You see, my grandfather used to be an entrepreneur. He was an amazing man. He started many companies and he was the life of the party. There are stories in the family of him and my grandmother riding around town on a motorcycle and a sidecart. Or so the story goes. You see, the man that I knew when I was a small boy was a mere shadow of this man, having suffered from severe depression to the extent that it robbed him of his love for life. And it made him not really want to have interactions with other humans, including his grandchildren. And it was only later in life that I realized that this was actually a big catalyst in my own life of being interested in the healthcare sector, of becoming a healthcare actuary, wanting to understand this trend of decline and diminishing as we age or we get sick. Why does it happen? How does it happen? And what can we do to prevent it? And my personal field of interest is wellness and longevity. And how do we live better? And in general, we've really become good at that, not only with healthcare, but in terms of our lives. The human population is doing better in nearly every single metric across the globe. Life is better. It doesn't matter if you live in Australia, the US, Imam, it doesn't matter. And this is actually what healthcare is about: preventing, reducing, and in the best senses, avoiding this decline, regardless of whether it's from old age or disease or any of the other factors. So to answer the question, maybe to add to Jeffrey's sense, is it optimistic talk? It's very optimistic. The future is extremely bright if you look at the things that are coming out of the world. We've learned many lessons in this conference: integrated care, greater focus on the patient, and getting back to the core of healthcare. But what I'd put to you is that the greatest catalyst for the future will be new technology. New technology is an extremely exciting field, and maybe the reason we don't focus on it so much, as Jeffrey pointed out, it's a little bit opaque, it's a little bit scary. And part of that is because we as humans don't do well with exponential trends. So new technology develops at an exponential rate. So to put that into context, if I took bigger steps exponentially, this is step 1. Step 4, I'd be at the back of the auditorium or in the lobby, and by step 30, I would have gone around planet Earth 6 times. We don't adapt well to new technology that grows at an exponential rate. It's something that we really struggle with. And when you think about new technology, we tend to think of it as things we will touch. We tend to think of it as things we will interact with. The telephone was a very eloquent example on the first day. But what I'd put to you is that new technology, the kind that will impact us significantly in future, is biotechnology. I'd like you to meet this little guy up on the screen. He's a fruit fly, but he's not any kind of fruit fly. For firstly, he glows in the dark. And secondly, he lives about twice the time an average fruit fly lives. And this was achieved via very simple gene modifications that were applied to him. And so when you tell me what's going to be possible in the future, what do you want to imagine? The eradication of some diseases? Why not the eradication of all diseases? Why not the ability to instantaneously heal yourself if you're involved in a traumatic event. If we think about it and we take it to an extreme conclusion, if we're really good at it, we might eliminate the need for healthcare as a concept. And what I'd put to you is that, given this bright future, the biggest challenge for us in the healthcare sector is not how bright it will be or to what altitude we will ascend to in terms of our ability to heal ourselves and make ourselves better, but it's the pace of that change. Because generally in the healthcare sector, we're slow to adapt. There's cost constraints, real constraints. There's constraints with the time it takes a doctor to learn how to be a doctor, which is a very expensive undertaking, financially, socially, and emotionally. To then expect them to change their behavior in pace or in tow with new technology is a big ask. And we've heard stories in the conference today about doctors that generally make bad decisions because that's the way they've always done it. And what I find myself thinking is, how adaptable am I to the pace of change? How adaptable is my own organization? And I'd put to you the question, how adaptable are you? How adaptable is your system? As Jeffrey pointed out, there are many similarities. And that, I think, is the great challenge of the new bright future of healthcare. It is extremely bright, but will we be able to adopt to it quick enough? Thank you.
Thank you, Daniel. Can I now ask Muna to join us for the 5 minutes?
Hello, my name is Muna, and I'd like to thank actually IHF and AHHA for this wonderful Congress and for giving me the opportunity to be here today and speak. This is my first time actually in Australia, and I must say I actually fell in love with Brisbane. I told my girls already I'm bringing them back and we're coming to enjoy this beautiful city. Our last session, and it's about the bright future of healthcare, and actually I do believe it's going to be a bright future. The keywords that I'm going to talk about is innovation, collaboration, and integration. We're going through the 4th industrial revolution, which builds on the digital revolution and is marked by emerging technologies, as we heard throughout the last 3 days. There are many: robotics, artificial intelligence, 3D printing, Internet of Things, and many more. I would like to share with you all what we have done in Dubai using some of these technologies that I believe that has had a really good outcome and has been promising both to our patients and to the system. We have done a value-based validation of augmented intelligence in medical imaging. Augmented intelligence works with and amplifies human intelligence. Augmented intelligence in automating chest X-ray screening for tuberculosis. DHA has 19 medical fitness centers across Dubai. And basically, we have a lot of visitors coming to Dubai each year, over almost 2 million. And these visitors have to have their, whether they're residing or working or coming to go through education, they have to have their visas renewed and issued every time. And for that, they need to undergo chest X-rays for every time they have this done. So the project went into phases, and over 4,500 chest X-rays were screened, and an AI algorithm was used. And we found with 95% sensitivity and 71% specificity that suspicious or abnormal chest X-rays for tuberculosis could be identified. This imaging platform not only removed traditional barrier to medical image exchange, but also enabled cross-site radiologist collaboration. This obviously led to reduced turnover time and kept their energy focused on what they need to look at and less on repetitive tasks. It has also created a vast data lake ready for analysis, which will move DHA from descriptive to more predictive analytic models. We heard that this morning, that data is so powerful and that it can really help improve early detection and introduce care plan models that will help enforce and improve patient engagement and compliance. This is only one technology used, and we are exploring the 3D printing in the dental services and the genomic sequencing for UAE natives. I would like to end by saying that technology can make us more patient-centric and deliver a value-based care. Thank you.
It's always very difficult when you followed, in effect, everybody summing up the whole process. So to try and say something different is always a challenge. We were asked to produce 3 words for this session, covering in 5 minutes. And I thought about changing my words, but I decided to keep with them. But I'll cheat by adding an extra one, which is the word learning. And and it was reflected in Jeffrey's stuff as well, about how, as a system, we've got to become more of a learning system if we're to face the challenges that we will face over the next 10 to 15 years. Chris Wormold, who's the Permanent Secretary at the Department of Health and Social Care in the UK government, came from education and into health. And he observed, as he went around the National Health Service for the first time, how much innovation there was going on everywhere in the health service and how brilliant this was. What he said was, I could never find a second adopter. There was never any, everybody was inventing things, but people weren't doing enough copying. And if you look at the amount of money, certainly our system spends on research, it's massive. If you look at how much money we spend on how do we implement this and get it actually out onto the ground, it's a fraction of some. It's done as an amateur exercise. So I'd add that learning point. I think there's a big cultural aspect, which I won't go into in addition to that. But I think that notion about how do we spread, because the big challenge for me across the whole of this conference, we have, I think, articulated well, and I think endorsed by Jeffrey's summary, articulated well many of the challenges and indeed lots of the solutions. The bit I still struggle with is pace and scale, because what we are going to be required to do over this next period, if we're to answer that big sustainability question, which is how do we make this system meet or even cope with the kinds of demands that's going to hit it over that period, how are we going to do that unless we increase the pace and scale of what we're doing? So my first word is integration. We've heard an awful lot about it. I'm not going to repeat lots around it, other than to say, of course, the fissures within all our systems. And that is the amazing thing about these conferences. You suddenly realize, you think, well, I thought this was our problem in our jurisdiction. But in fact, of course, it's exactly the same problem. It's not exactly the same problem, but dimensions of that problem are appearing in all these other places as well. Integration is the buzzword of the moment within the UK. Everybody talks about it. It's interesting that we've had integration in Northern Ireland and in Wales certainly in Northern Ireland, for about 30 years. And I have to tell you, it hasn't produced a brilliant healthcare system. So my lesson from integration, and not wishing to be pessimistic at this point in the conference, is that it is necessary, absolutely necessary, and you've got to get it right, but it obviously, of its own, it is not sufficient. We have many fissures and divisions within the way we present healthcare. To the patient, none of these things matter. Words like primary care, community services, social care, all provided differently in our jurisdiction, and half the time are not talking to one another. The difference between primary and acute care, between secondary and tertiary, none of these divisions make a damn bit of difference if you're a patient and you're trying to work through what in effect to you probably looks like a relatively simple supply chain. We've got to sort out our supply chain. And the good news is, I think that an awful lot of places are starting to do this. I come back to my pace and scale point about how do we take this on and drive that forward, and also recognize that as we do this, it's not necessarily going to be cheaper. I mean, for years people said, if only we could get people to stop smoking, we would save all this money. Of course, it's nonsense. Getting people to stop smoking was one of the best public health interventions, the leading one of the 20th century. And it remains that challenge today, not least in terms of health inequalities. But it didn't save any money. It's actually cost a huge amount of money to healthcare. Because, of course, people, instead of dying in their 50s, are living longer and are having all sorts of other long-term conditions, which we are having to pay for. So don't let's sell it on cheapness, but sell it on value. Sell it on what we're meant to be doing, which is about changing and supporting people's lives. My second slide is word is engagement. And I want to begin, first of all, I think you can change the slide now, otherwise, thank you. The first is around patient and user engagement. And again, we've talked a lot about this. This is an area which, as a system, I think we've attempted to tackle many, many times. But I don't believe that we have as yet fully dealt with that issue, and how we change the way that we relate to patients and recognize that their role, not least because for the first time, I think, patients are starting to have the levels of knowledge, not just about themselves, but about their conditions, which will change the nature of that engagement. And thirdly, because my time is running out, I want to talk about technology. And again, this has been something that's been touched on. It isn't a panacea, it isn't a savior, but it will absolutely shape what we do. And it will shape what we do not just at the hard, acute end of advances in medical technology, but advances in AI, advances in digital technology can and must change the way we deliver the whole range of care from the first appearance of the patient or indeed before somebody becomes ill. Mobile technology is already affecting the way that community nurses and others deliver in care. But remote monitoring, artificial intelligence, they're going to transform the way care is provided to patients, and they will streamline back office functions. Data, again mentioned many times in this conference, can and will transform the way services are targeted and the way they're run. Our ability to identify where there is need and to put interventions in place. These are, as I say, not a savior, but they are absolutely critical if we're going to provide. So my message is go forth, integrate, engage, and embrace the technological revolution, and we will create a sustainable health and care system. Thank you.
Thanks, Niall. This technology issue, which is the theme of today, but of course has come up so much, reminds me a lot of the Kodak story. We all know Kodak, the camera company. I'm going to direct this to you, Jeffrey. Kodak knew digitisation, digital technology was coming. They were in fact involved very much in its development. However, they were so confident, and perhaps one would argue so blind, that they couldn't foresee that it would in fact eliminate them. And it wasn't the fact that it existed, it was the inability to recognise its impact. And what I'm curious about, we're talking about the bright future, and I know that you're a raving optimist. If we're casting bright futures, bright lights illuminate flaws. Bright lights allow us to see the detail and the shadow and the texture if we have enough light. What I want you to do is, I want to sort of imagine, what are these invisible foes, like Kodak? They saw it, they knew it was there, but they really didn't appreciate it. What are those invisible foes that are existing in the health system that you think will in fact determine whether we have a bright or darker future?
And there's lots of examples like Kodak, where people get stuck on railroad tracks. One of the things that is difficult for humans, I think, is firstly to live outside the moment, to think about 2030 and getting there. And it's very difficult for us not to be stuck on railroad tracks. So you can think of lots of examples. Nokia is another example. It basically had mobile phones sewn up and knew about the iPhone and iPhone-like products, but it wasn't nimble enough. So the healthcare cart is also stuck in a rut. And we're pushing it as hard as we can. That's where all speakers spoke about technology being a solution. But if we are like the drunk, looking for the keys only under the lamp, because that's where the lights are, and we're not looking elsewhere, then we're going to get into difficulties. we've seen that in healthcare. In my time, the electronic medical record was the solution. Before that, in Australia, we got obsessed with case mix funding and DRGs, and it was apparently the solution. So faddism is rife. Where I'm encouraged, though, is I just remember this little aphorism that says, no one of us is as smart as all of us. And collaboration is the only way to do this. Hearing different voices, trying to encourage governments, even democracies, to listen to alternative viewpoints. We can't just fashion a future for 2030 and then go there, because the technology that Daniel's been talking about is going to change tomorrow. So having broad-based goals, not getting stuck in a rut, being pluralist about this, taking advantage and opportunity, like our other two speakers spoke of, is going to be what we're going to do. Now, that does not sound like a prescription for the future, but that's the prescription for the future. It doesn't sound precise enough for many people. So it's going to be 2 steps forward, 3 steps back, and 1 step to the side. A bit like Alison dancing to the bush band the other night.
You two can take that up after the session, okay?
I just want to add on to Jeffrey. What makes it harder is it's going to get harder in the future. On the first day, there was the speaker that eloquently talked about how we would think of a phone 30 years ago. The reality is that they, 30 years ago, had a larger statistical probability to correctly predict the iPhone than we do in the next 5 years to know what telecommunications would look like, because of this growth trend that we're on. So it's a very big challenge, as Jeffrey pointed out, and it's going to get bigger into the future. And then the other point as well, taking a note out of my wife's book, she's a health economist, there's this thing of hyperbolically discounting the future. We don't like change. We like where we are now, and we don't want to think of severe disruption in the future. You know, it's why we had die-offs in terms of the ice age and things. We're not great at adapting very quickly. We're great at adapting slowly over time. And we tend to think linearly, but it's going to be a big challenge, and it's going to get bigger as we progress.
Any other comments on that?
Well, just on the question of not being able to predict, I think that's absolutely right. And if you look at something like the internet and some of the downsides, which we're all very much aware of, I think we need to be cautious and wary. On the other hand, I also think, partly for the reasons just described, there's a natural conservatism. And actually in an area like healthcare, where you'd think people would be wanting to embrace technology and take things, because medicine itself, of course, relies very heavily on that technology, we've been amazingly slow in relation to the digital revolution. I remember Mike Richards, who was the Chief Inspector of Hospitals in England, complaining when he was the cancer czar, that the only people who wrote to him with long-handed letters were his fellow consultants. Everybody else had moved on to email. So, you know, there is something about, you know, mindsets here. So while I'm really wary, because I think there are human rights, there are all sorts of issues and challenges with all this, we've actually got to go out and embrace this stuff, because if we don't, then we will not create a sustainable system.
And I guess one of the big issues that keeps coming up in relation to this is this cost issue. And I know, Mina, you referred to this, and you're talking about the example of 3D printing, for example. How do you wrestle the tension between technology and cost? We've sort of had a bit of a chance to explore that in a number of panels. What's your take on that?
So I think, Ursula, you're right. I mean, and everybody alluded to this. It's not cheap. And to deliver healthcare, or to get especially technology into healthcare, it is expensive. But at the end, I think we're looking at the value that you're delivering. So if you do the calculations right, you know, for example, the example I shared with augmented intelligence and the, you know, huge amounts of chest x-rays that were read, over 1 million. If your resources, yes, you're going to spend a lot in the beginning, but if you use that and utilize it for the correct purpose, and then you have people that's saving their energy to do better things and you know, diagnose earlier, instead of having the report in a week, you're having it now on the same day. because the artificial intelligence is helping you identify those, suspicious or suspicious X-rays, for example. So I think it's a balance, and yeah, it might sound upfront that it is, a lot of money, it's costly, but at the end, if you're using it wisely and the wise technology, it does pay off.
Because the other aspect of this in relation to that is this point that Niall's making, that there's a bit of a Ludditeness and conservatism, and I also know that that's associated with fear as much as anything, and also control, two sides of a different coin. I take the example from the banking industry, when ATMs were brought in, something that's been in the literature a lot, and the people who were the bank tellers, initially were really concerned they were going to lose their jobs. But what did we find? We found that actually those bank tellers were freed from the mundanity of just dishing out the money, because the ATM did it. It was expensive technology, but it actually enabled them to utilise and develop other skills, which also included increased profits for banks, because you could actually sell product that a machine couldn't do. So I'm sort of wondering, how might technology occupy that kind of a role? Because we get a bit caught up with the sexy stuff, and I'm just sort of wondering what do we, as a group, what do we feel is potentially our ATM in medicine? Do we have some ATMs in medicine that you're aware of or would like to comment on?
The interesting thing about ATMs is they're going to go out very shortly as well. So it's a piece of intermediate technology, I guess. I think one of the areas that we haven't touched on a lot is the whole issue of back office and how back office will work. I mean, I don't pretend to be an expert in it, but certainly the suggestion is that an awful lot of actually the kind of things you were describing, which are routine process type activity, will be possibly quite quickly wiped out. I mean, I think there are genuine issues, social issues, around about another wave of removing an awful lot of fairly manual style or process-driven jobs, which as a society and in mental health and all those other things that we faced with the first industrial revolution, I think we're going to face it again. I was actually standing in Parliament Square in London, waiting to cross the road, and about 15, I think 14 of them were driven by men, incidentally, but 15 vans passed me by. And I just wondered, if you roll that forward in 15 or 20 years, will those actually be driverless vehicles? And the question then is, what happens to these people? And will we have adapted as an economy, or indeed, in our world where we're desperately short of human beings, and we still will be in 10 or 15 years, can we convert? And have we got the adaptability to bring them in?
Comments on that?
I'd like to add on to that. So we do have examples of ATMs. There's a couple in New York already where you walk into a pod and you talk to a team of healthcare professionals. In remote areas in Africa, there's a lot of examples of cell phone-based medicine, app medicine, diagnostic tools. The key there is, again, it doesn't supplant the doctor. It brings the doctor closer to the patient. Healthcare is such a unique thing because you're so vulnerable when you're sick, when you need a doctor. It's even in my own world, in terms of embracing technology as an actuary, of course I'd love to, because it'll make my job easier, and maybe one day someone won't mind getting a financial report from a machine. But I think we're very far off from wanting to circumvent the doctor. You want a doctor in that space. And I think what it will do, it will relieve some of the pressure there. The challenge there as well is it also manifests in the cost of new technology in healthcare. So if you think about something like a Kodak, or even an example as a Tesla, if you bought a Tesla, it's still a car. You don't need to go for specific courses to drive it. You can drive it easily on your own. New technology in healthcare remains expensive. And this is a bit of a strange thing, and it gets back to the cost point. The reason is because you need an ever more expert to drive it. Think of the Da Vinci machine, which you've heard. You can't just prop any surgeon behind a Da Vinci machine. They need specialized training, which means that it takes more time for them, which means they're more expensive. So it's difficult to bring those costs down.
Do you think that's, in a way, ironically, part of the dilemma that we're now facing, is that we're being smart, but we're not being clever, or the other way around? So we've got these tools that are so sophisticated that, as you say, they're actually increasing the likelihood that we're not going to use them, or we can't use them to their full benefit. So there, at the end of the day, then that sits in the white elephant in the corner. I must admit, though, I've also seen that when you put an ultrasound machine in a country where there's no power source. So I don't necessarily it needs to be a Da Vinci robot doing your prostate surgery. But I'm just curious about that too, about how, once again, do we have that tension between, we almost come up with stuff that's almost so smart, so good, but we then don't have the capacity to actually fully harness it. Any comments on that? About how we can go about actually harnessing our own intellect a little bit more cleverly in the use of, in the construction of our technology in healthcare.
I think just to build on what was said, I think that it possibly is about getting people to work towards the top of their license. We're certainly misusing large numbers of staff at the moment who, if we use technology in the right way, then we'll reach the top of that. I don't really know is the short answer to your question about the very advanced stuff and not being able to use that. I think the biggest impact will be changing the kind of patients that we're able to treat, our ability to identify those patients, and then the interventions that follow that. I think that's something, as a system, even dysfunctional as we are, we ought to be able to do.
I think, Ursula, it's, as we learn, and we heard even on the first day, for example, using of robotics for doing so much surgery. And at the same time, we know that it's not really in any way better outcome. It's similar to your laparoscopic procedures, but it's more costly. So, and this is, I think, what has driven now the market to have many more, different than the Da Vinci, and they're coming up with, I think, other different robotics which can be more, less costly. However, I think this is where we really need the tools to identify what is good and what would work. I think, as the information and technology gets more and more, you're going to see a lot. And it's not everything or every intellect that we must take. We need to identify what's best for our patients and if it's really going to change any outcome. So it's, I think at the end of the day, it's not about I use robotic and I do this surgery versus I do it laparoscopic. If the outcome is the same, do I really need to use that?
We've got to hone a couple of skills. One is, you are absolutely correct, Mona. We have to get better at thinking the starting point is the patient. We sometimes do that, and then we fall back on me thinking about research first, or the provider thinking about providing care that has to be delivered to the patient without focusing on the patient and asking the patient. So that's one skill that we really are halfway over the fence on. We've got to hone that and really build that into healthcare. The other thing is, it's this notion of the bright future for healthcare, and you've challenged us in a way, and we've all been optimistic. I just want to reframe that slightly. So it's okay to be even excessively optimistic, but I think we also have to be realistic. We have to be much better at managing change and bringing things to scale that do make a difference. Yes, it is going to cost more. I'm mindful of the fact that I often think about the health system and us wanting from the health system three things, and we want all three, and we can't have all three. What we want from a health system is for it to be good, quick, and cheap. Most people have heard this, but the reality is we can only have two of those three. If it's a good, quick system, it will not be cheap. If it's a good, cheap system, it won't be quick. And if it's a quick, cheap system, it won't really be good. So we sometimes put all our eggs in one basket, saying we want everything for the health system and everything for our patients, and we want to exploit all the good technology. Sometimes we just have to be a bit humble and say we can't be excessively optimistic. We can't say there's a completely bright future for healthcare, because we have to make, in a complex adaptive system, trade-offs. We have to decide and make tough choices. We often don't deal with that very well in conferences like this, but we should.
No, I absolutely agree with that. And you talked this morning about health technology assessments, and again, different countries have different methods of doing that. And certainly, health technology assessments with great respect to actuaries and health economists and so on, there's an awful lot of objectivity alongside the subjectivity in those decisions. I mean, we have a figure, I think in the UK, it used to be around £30,000 for that, for a quality adjusted life year. And you could have a discussion with a health economist who would hold this up as being, very objective, very fair. But if you said to them, well, actually, within a mile of where we are sitting now is a social care institution where there are people with very, very severe disabilities. And we are spending, rightly, because we're a civilised society, we're spending up to £250,000 a year to keep these people alive, even though we're not even sure necessarily about the quality of their lives or their ability to communicate. At the same time, you're telling me we're going to deny a 45-year-old mother who's got a 9-year-old child and she's got 9 months to live, and there is a drug that may give her an extra 2 months in life, and you're going to deny that, and you're saying that's a fair system. Well, the answer is, of course, it's manifestly not fair. But I do think we need to, I don't think there is any alternative but to have systems where you got limited amounts of money and you've got the levels of demand and the new technologies so that we make the best use of the resource that we do have and have some form of assessment about whether we're going to apply it or not.
And on that note, we have actually run out of time, unfortunately. We have only just scratched the surface. As you can see, this could run on. But the good thing about Australian Sundowners is it does involve beer. Whether you drink it or the person you're talking with drinks it, it's there. And this conversation is no doubt something that will invariably be continued. I would really urge you to continue this because we really did only start to scratch the surface on this notion of bright and future and also this joining of health and care. So on that note, can I ask you to thank our panel members for this final session?